So good afternoon, everybody. And today we are going to continue our grand round, and this is going to be an interesting one with a girl with rickets. So we have been talking about different case scenarios in which how the cases may present and what could be a possible. And, with a girl with rickets. And we are going to look into the various aspects of how we can reach a diagnosis based upon clinical parameters with minimal workup, minimal evaluation. This will be the theme on that regards. And this is part of our Grand Round series in which we are going to cover some interesting endocrinology scenarios. So rickets is a very common scenario which can present to a pediatrician as a pediatric endocrinologist, and there can often be a lot of challenges. So this is a case which will highlight how it can be confusing, and often we'll say the rickets approach is very simple. All you have to do is to look at the phosphorus level, the blood gas level, the PTH level, and you will get the diagnosis. Now, this was a 12-year-old girl with multiple fractures, and we can see significant bony deformities, loser zone which are there. Very clearly, she had failure to thrive, polyuria and myopathy. She had metabolic acidosis. Now, often if we talk about fractures with acidosis, we know that we are talking about RTA. But the other possibilities which we may have to think about include renal insufficiency, which could be a possibility, and whether you have a secondary hyperparathyroidism, which is also causing some amount of Fanconi syndrome causing mild metabolic acidosis. Now, the other clue here was the presence of hypokalemia. Now, if you forget about rickets, you say acidosis and hypokalemia, you only have RTA as a possibility versus a GI loss. If you club with rickets, RTA becomes important, and there also you're talking about distal RTA because you're talking about hypokalemia at presentation. So now further workup here showed that she had a normal anion gap. Urinary anion gap was positive, suggesting that there was an issue in terms of renal ammonium production, indicative of distal renal tubular acidosis. And subsequently, there was found to have hypokalemia, and urinary pH was 5.8, which basically is indicative that despite having acidic blood, the urine seems to be not that much in terms of the acidic terms, and therefore it was suggestive of a case of distal RTA. The confusion, however, came out was that she also was found to have amino aciduria. Now, this is something which is usually seen in the setting of a proximal RTA. Now, this case clearly has two features, proximal versus distal, and therein lies the significance of where the clinical findings are. So, if you ask me clinically, this is a girl who has severe bony deformity, severe failure to thrive, hypokalemia, severe acidosis. The first possibility will be distal RTA. Now, I have to tie the clue as to whether this could be proximal RTA. The classical presentation of proximal RTA is early onset rickets with hypophosphatemia with normal potassium in most cases. Now, amino aciduria can occur in anybody who has got persistent secondary hyperparathyroidism because of the Fanconi-like picture. So here, because of this hyperparathyroidism, this amino aciduria picture was confusing in that regards. So the key message is when you're looking at a case of rickets or any other case, you should look at first the clinical possibilities. And then only you go ahead and look into the diagnostic possibility and consider workup from that perspective. So all of you can go and have a look at our website, learning.society.in, which has got multiple courses and resources related to pediatric endocrinology. Our YouTube channel, which has got extensive resources, various courses which are available, including the fellowship course, the pediatric endocrinology for postgraduate course, our multiple grand rounds PG lecture series, which run every twice a month at least to cover different aspects of pediatric endocrinology. Our publications, including pediatric endocrinology protocols, basic and advanced pediatric endocrinology, our mobile application, which will help you in terms of evaluation and management. So today, what we'll do is that we'll discuss in detail about this particular presentation. And this girl, when she was referred to us, was labeled already. So the key issue is that do not label when somebody comes to you. Look at the overall clinical picture and then make a decision as to what you're looking at. Because often if you put a label, then the thought processes will go off and everybody will continue diagnosing in that perspective. So I'll now hand over to Dr. Sandeep, who will carry forward with regards to the case scenario.
Thank you very much, sir. Good afternoon, everyone. So in this grand round, we are going to discuss about a girl who presented with bony deformities and she had low phosphorus at presentation and subsequently was labeled as hypophosphatemia rickets. The chief presenting complaints in this girl, she was 4 years, 5 months old female child, and informant was mother, and the information given was reliable. She was first product of third degree consanguineous marriage. The main complaints were poor growth since last 2 years. There was low height gain and weight gain. It was associated with difficulty in walking, and there was various deformities were present since last 1 year. Also, mother complained that there was polyuria and polydipsia since last 1 year. So, history of presenting illness. Basically, the main complaint was growth failure. Mother noticed since last 2 years, baby is lagging behind the peer age group, and there was low height and weight gain. Also, there was difficulty in walking. Till 2 year of age, she was walking without support. However, gradually there was uh, regression in the gross motor milestones, and presently she can only stand with support and walk with support.
If you now So if you now look at a scenario of a child who has an early onset failure to thrive, along with that, there seems to be a motor developmental issue. Without going into the other aspect, what are the possibilities you will think of, Dr. Nimit?
Rickets could be one possibility. Then I said RTA could be the.
If you talk, let's not go into polydeformities first. If you say somebody has failure to thrive and delayed motor development, yes, you have immediately get what else can you call this?
RTA and
RDA. Any other thing? Dr. Alpha?
Any myopathies can
So
present.
you have to think of all the possibilities. This is a very wide perspective. Any call of chronic systemic illness will cause a similar scenario. So all those things have to be treated that way. If you narrow down in terms of the rickets, if you look at specifically in terms of rickets, what are the possibilities now? So at this age, early onset failure to thrive, delayed development in terms of motor milestones and rickets. What are the possibilities you'll think?
So first of all, we'll consider the most common thing, nutritional rickets will first will with the DD, sir. Subsequently, based on the severity of growth failure, the patient may have RTA or CKD can be the possibility.
So what is the usual presentation of nutritional rickets?
Usually, nutritional rickets starts after the age of 6 months, sir.
Okay. And then the course?
Course will be, there will be initially, there will be hypocalcemic features will be there initially at stage 1. And subsequently the parathyroid hormone will increase and the calcium will normalize.
So currently her age is?
She is 4 years, 5 months.
So is 2 year onset, like you said 2 years ago she had symptoms, is that the right timing for nutritional rickets or a bit late?
It's a bit late.
So that is something which is going against nutritional rickets. You can have developmental delay that can happen. But what you are saying is that there is not much developmental delay. There seems to be, if at all, quote unquote, regression. So was the child walking normally before 1 year?
Before, till the age of 2 years, he was now walking normally.
Yes.
Sir. Gradually, there was regression. He was not.
So this is an important parameter. We are talking not about developmental delay. We are more talking about something new which has happened. So that will go against nutritional. So now carry on.
And also, mother noticed that there were various bony deformities. The chest was protruded. She also had swelling of wrist and swelling of knees. Also, there was knock knee was there. And subsequently, the child became very less active. The appetite decreased. She started consuming more water, and she passes more urine. There was no past history of recurrent fractures in the child.
So now, if you go from a different perspective, early onset rickets. What are the causes of early onset rickets?
So early onset rickets, one of the most common causes are like RTS could be present in early onset, like vitamin D resistant rickets could be also present like early onset. Hypophosphatic rickets are a bit late, but sometimes it can present within 1 year of age if it is a severe one.
Okay, which form?
Which the X-linked
Excellent.
Okay. What is there from that perspective?
Yes.
But yes,
earliest onset should be the rickets should be the proximal RTA induced.
VDDR. If you have vitamin D, type 1, months with severe listening, and they have a lot of hypocalcemia. They will present you with hypocalcemic
Seizures.
seizure and severe rickets. So that will be the first to present. Second would be metabolic bone disease of premature. What is the time? So this is not premature, I'm talking about early ones. What is the typical age at which the MBD will present?
Around preterm, may they are more common than
Preterm child, what age you should be looking at in terms of clinical, biochemical, radiological features?
after 1 month of age.
Actually 4 to 6 years.
Till that mother
Calcium absorption in the first 2 to 4 weeks is not very much dependent upon the vitamin D status. And you have got enough which is coming from the feed. Typically, you have a time around 4 to 6 weeks in your AFP anyway. If you look at the AFP profile, it will happen around 4 to 6 weeks. This is the time where the formation becomes more. Bone formation becomes more, and you would be needing more amount of phosphorus and calcium. So earliest onset we can say, one of course in the setting of prematurity, this metabolic bone disease. Second is vitamin D dependent rickets. Third will be proximal RTA, distal RTA. Now, if you want to differentiate between RTA, proximal versus distal, which is more likely to present earlier?
Distal RDS. Because they
In
present
terms of
fracture-
rickets, who will cause rickets? Who will cause rickets earlier? Proximal will cause rickets earlier. What causes? So now this brings you to the pathophysiology. What causes rickets in proximal RTA?
Hyperparathyroidism.
Hypophosphatemia.
Hypophosphatemia.
What causes rickets in distal RTA?
Due to metabolic bone disease due to acidosis.
Mainly because of acidosis. So phosphorus deficiency is going to present with rickets much earlier compared to acidosis, which is more like a illusional effect. So the other way to think of it, if you go by classical Western textbooks, they will say distal RTA does not cause rickets. Proximal RTA causes rickets, but distal RTA does not. But in our overall study, we will find that distal RTA is a very common cause of rickets. So what do you think is the reason behind that?
There is a hypercalciuria also, sir. Borderline calcium is there. Hyperparathyroidism.
Anything else? Which the clue is there that distal RTA will cause a later onset of rickets. So if you are able to pick up distal RTA because of failure to thrive, because of hypokalemia, because of polyuria, because of other symptoms, you will start treatment and you will prevent rickets. So this girl, if you go by history, now if I go by history, you are saying the onset is not very early. It's around 2 years of age.
Okay.
So it's too late. Can it be VDDR? Now let's go one by one.
So VDD could have presented with hypocalcemic symptoms.
Hypocalcemia, plus minus, sometimes it's not there, but it will be much earlier onset.
Yes.
Proximal RTA,
And proximal RTA
it's a bit late.
late.
Whatever proximal RTA we are seeing, it's around 1 year, 1.5 years, severe fracture, severe failure to thrive and other things. So those two things becomes less likely. Hypophosphatemic rickets, this is a bit too early for hypophosphatemic rickets. So if you just look at the age of onset, then distal RTA becomes important, but then you can carry on from there. Yeah.
So there was no history of diarrhea, abdominal pain, pica, or increasing pallor to rule out malabsorption or celiac disease.
And yes, so celiac disease, what age typically will it present?
Celiac will present 2 years or not.
So in terms of rickets,
It will take time.
so generally celiac will start only once somebody starts on gluten diet.
Yes.
That is typically around 9 to 12 months. So the onset of symptoms will be like 18 months. Failure to thrive will happen by around 2 years. Rickets will be like 4 or 5 years. So it's a bit later. So that true is a good possibility, but it's a bit too early for celiac also from that regards. Yeah.
There was no history of oliguria, edema, or feature suggestive hypertensive emergency to rule out.
Why are you looking at hypertensive emergency?
We are trying to rule out CKD by clinical negative history, sir.
Yes. So chronic kidney disease can present to you with rickets.
Yes.
Again, the onset of rickets is a bit too early unless you're saying it's like a congenital disorder. But then they will have many other features.
Yes.
So is rickets a early feature or a late feature of CKD?
It will be late feature.
Generally, you will have many other features to pick up. So by the time CKD presents to you with rickets, you will have many other features which are there. Okay, carry on.
No history of seizures, spasm, or facial twitching to rule out hypocalcemic symptoms. There was no history of chronic consumption of any drugs to rule out tubulopathy-induced RTA.
Which drugs are you talking about?
Any chronic consumption like sir, aminoglycosides antibiotics or
You can take aminoglycoside for 2 years. And the
acetylcholinesterase,
tubular dysfunction would be
lead poisoning,
transient. So which drugs? That's why I'm asking. Now you're coming into the right one,
poisonings
which
like
can be used for long term.
the poisonings like lead poisoning, copper poisoning, mercury poisoning.
But you talked about drugs, especially. Which drugs cause RTA? Yeah, that obviously will not get a involved in that. So these are obviously very significant. But
Topiramate.
if you have somebody on anti-epileptic drugs, those sort of drugs can cause that. That chronic consumption of drugs. Which other drugs can cause rickets other than RTA
Those increasing
or metabolic bone disease?
those increasing vitamin D metabolism.
Yes, like
anti-epileptics.
phenytoin,
Phenytoin.
phenobarbital, that becomes important. Yes, carry on.
No history of prolonged jaundice or visual disturbances or deafness. Rule out congenital form of distal and proximal RTA. No history of similar illness in the family. So we'll now go to birth and antenatal history. Antenatal history was uneventful. The baby was full-term normal vaginal delivery, cried immediately at birth. No resuscitation was given. There was no history of NICU admission, but the birth weight, as recalled by the mother, was 1.5 kg. She was exclusively breastfed for 6 months. Then subsequently, complementary feed was started. Developmentally, she was normal. The development was normal till age of 2 years, and there was gradual regression of gross motor milestones, maybe due to limb deformities. Other milestones were within normal limit. Presently, she can stand with support and walk with support.
So would you like to take a history regarding some acute episodes also in this case? So when you said that there was a probably she was walking and now not able to walk,
Yeah.
anything acute will give you a clue to diagnosis. Suddenly something happens to the child.
Trauma. In
No.
fractures.
Yes. So that will be important to ask about periodic paralysis. That is something a very common presentation of distal RTAs, hypokalemic paralysis. So what other condition can cause hypokalemic paralysis and rickets? Anything else? This condition causes rickets and hypokalemic.
Celiac.
Yes, you are either using either kidney or either kidney. Number of patients with celiac were presented with hypokalemic paralysis. So this history of hypokalemic paralysis will be important from that regards. What other histories will you ask for somebody with RTA, suspected RTA?
We'll ask for the history of jaundice, seizures.
That you have asked. Anything more in terms of symptoms?
Polyuria, polydipsia, we already asked for.
Polyuria, polydipsia, hypokalemic paralysis,
Hematuria, sir.
hematuria.
Hemoglobin or nephrocalcinosis, sir.
Yes, that will be important. Yes.
What is the significance of jaundice?
Proximal RTA.
Yeah,
Erythromelia.
sent it much late, but not only in the early stage, the jaundice is not there.
Basically, proximal RTA, and we have a pancreatitis, then jaundice of cholesterol may be there.
Yes, sir.
And rickets is something which is additional. But here the predominant presentation is
Bone deformity.
that thing.
There was no history of similar illness in the family. She's the index case, and the other sibling is normal. Nutritionally, there was loss of appetite and refusal to eat, which leads to a deficit of calorie and protein intake as per against her RDA.
What other things can point out to RTA in this scenario? One is deafness. So you should always take a history of deafness because many of these congenital forms, which we'll discuss a bit, are basically associated with deafness. So always taking a history of that becomes important.
There is no history of any drug consumption.
Mhm.
She belongs to a low middle class as per the modified Copersomia scale. Sir, will give a diagnosis based on the history. So she is 4 years, 5 months old female child, first product of consanguineous marriage, presented with failure to thrive, gait abnormality, bony deformities, and polyuria, polydipsia. So,
Okay, so let's hold on to that. Failure to thrive and polyuria, polydipsia. Differential of that first. So when you look at these differential, you should always try to draw Venn diagram. This is failure to thrive. This is failure to thrive with polyuria. Failure to thrive with polyuria with rickets. So failure to thrive with polyuria, RTA we already discussed. What else?
DK,
DI,
DI.
nephrogenic DI. DK, it is you can't be going on for 2 years. So DK will be less likely. Diabetes insipidus, as Dr. Vibha has said. Anything else? Tubulopathies. Any of those tubulopathies can cause that. CH, like aldosterone resistance, type 4 RTA sort of a picture. That is something which can present like that. Can celiac cause polyuria?
Yes.
So those will be the ones which will cause polyuria with failure. Now you are having again. Then quite narrow. Crystal rickets can it cause polyuria?
If it is severe one, sir, and long last for long time, hyperparathyroidism will lead to phantom-like pictures.
Mild tubular dysfunction. Although that will not be a typical presentation. Celiac should be there somewhere in the differential because this is an important differential here.
Yes, sir.
Chronic kidney disease, yes, I would be a bit less likely, especially with polyuria. Which types of chronic kidney disease will cause polyuria?
The early phases in the ATN, sir.
So tubular. So again, you're talking about predominantly tubular disorder, not a glomerular disorder. So that should be less likely. I think celiac will come up. Dr. Vibha, anything else? Dr. Alappan? So I would say this child is too early in terms of hypophosphatemic rickets, so that becomes unlikely. It's a too late for nutritional rickets, and probably the severity is more. It's too late for proximal RTA. So if you're talking about going overall from clinical terms on history, distal RTA will be a strong possibility, which we are looking at. Carry on.
So we'll move ahead to examination. In general examination, the patient is conscious oriented. GC is 15/15. Baby is sitting comfortably in mother's lap during examination. The vitals, heart rate is 108 per minute. Respiratory rate is on the higher side, 32 per minute. Fast and deep breathing is present. Blood pressure is 98/60 millimeters of mercury between 90th to 95th centile for age and height. sp2 is 98% room air in the right arm. Temperature is within normal limit. There is no pallor, cyanosis, clubbing, edema, icterus lymphadenopathy.
If you say hypertension with polyuria causes
Hypertension with polyuria, TKD, sir. Early phase.
see your basically both things won't match. If you have polyuria, then hypertension will be less. Anything else?
Aldosterone.
So increased aldosterone effect like Liddle syndrome, apparent mineralocorticoid excess, or hyperaldosteronism, any of those disorders can present. But this is a single reading. Of course, you cannot just rely on that. But yes, this could be a clue. What do you expect the volume status in RTA?
Volume status should be on the lower side.
Yes.
In RTA, there is in the distal RTA, the channel H plus K plus ATPase channel is defective. So the potassium is not going inside and it is lost by the U. Also, the mechanism of acidosis causes RTA. By acidosis, the body wants to less conserve the potassium. It will excrete. Hypovolemia is the one of the important cause causing increased aldosterone and further less of.
And for anybody to have a sustained hypokidemia, you need to have increased which happens. So now, basically or otherwise, this is fine. Carry on.
In anthropometry, height is 77 centimeter, which is minus 6.28 SDS. Weight 10.2 kg, minus 6.73 SDS. BMI 12.1.
What is the role of BMI at this age? So how do you assess nutritional status in less than 5 years of age?
Based on the weight SDS.
Weight for length SDS or weight for height SDS in this case. And how do you interpret that? What is underweight?
Less than minus 3 SDS.
So +2 and above is overweight, +3 and above is obesity, -2 is the criteria. So weight for height SDS should be suspected. Now, if you look at these figures, when do you think the growth stopped? At what age? 1 year or even before that, because she might have grown something. So it's somewhere around 9 months, 12 months, the height stopped.
Yes,
But the other problems, bony deformities, started happening a bit later.
yes, sir. After-
Typically, you are talking about 1.5 years more
yes,
beyond that. So there is a clear-cut dichotomy. So there is something which is affecting growth first, and then it is affecting the bone. If it was proximal RTA, you will have deformity right in the beginning.
Yeah.
And maybe the failure to thrive is there, but not to this severity. So now if you look into your picture again, can this be celiac?
I like, like,
Celiac is pretty much out. Can we look at nutritional?
yes.
there will be no such growth will not be like.
It's too much. So when you say nutritional effects, it's a very blanket statement. So it is nutritional effects, but it is because of some other form which is affecting. You need to understand that form. It's not that simple between that or the scenario. So I think those two possibilities are out.
Malabsorption.
Yes. So malabsorption due to some other reason. So celiac is unmet. Yes, malabsorption due to other causes can be there. And Rickets is a later manifestation of this system. We are having first severe failure, then Rickets is happening. Yeah, we know. It's too early for pregnancy also, like within 6 months, 9 months, time. Yes, so we got normal at birth. So this child was normal at birth, walking, and then for the last 2 years of office, something which will happen later on, it is a different.
Severity of the growth failure, is it correlating with the in this minus?
It is something which is affecting growth. Rickets is also being, bone is also being affected a bit. So predominant effect is on growth. So then again, if you go by our own hypothesis, we are seeing that this could be more likely to be a distal RTA as compared to any other diagnosis. VDDR, you don't expect this level of growth failure, and there is no hypocalcemia. So again, if you look in that regards, proximal RTA, late presentation.
Yes.
Distal RTA, it's fitting pretty much into it, but of course, you have to go ahead further on that.
She's prepubertal with the staging of B1, P1, and M0. In head-to-toe examination, there was frontal bossing, pectus carinatum was there, Harrison sulcus was present. There was widening of wrist. Apart from that, there was widening of knee joints and genu valgum was present.
So out of genu varum and genu valgum, which one is more clearly a pointer of a pathological cause?
Varum.
Genu valgum. Yes. If you have genu valgum, that can be a physiological response. Genu valgum, for that. What is genu valgum?
Backward bending. Backward bending of the
Bending is there. And windstroke is also clear cut.
Yes.
But then everything seems to be wind. Yeah. Carry on.
in systemic examination, the cardiovascular system was unremarkable. In respiratory system, Kussmaul's breathing was present. Bilateral vesicular breath sounds were heard, and air entry was equal bilaterally. CNS, PT
So,
was constant.
small breathing in a very specific term. So what exactly do you mean by small
It
breathing?
is fast and rapid and uh, deep breathing. Sir.
Deep and rapid.
Yes, sir.
So it was like that, or you can say more clearly acidotic.
Acidotic.
Generally, we talk about small breathing in the setting of a CNS
Sir.
issue. So this will be more like a acidotic.
Acidotic.
So compared to DKA, do you think it was similar to DKA
It is kind of similar to DK.
in this case also? Okay. So again, if you talk about the polyuria with failure to thrive, with bony deformity, with this, I think we are now coming very closer to our diagnosis.
In CNS, she was conscious, alert, cooperative. Tone was normal. Power was 5/5 in all limbs. Deep tendon reflexes were present. And by crude method, the vision and hearing were normal. In the per abdomen, abdomen was soft. There was no hepatosplenomegaly, and on inspection, the abdomen was scaphoid.
So this again is a big clue. So lack of hepatosplenomegaly is against
Glycogen storage disease or tyrosinemia.
proximal, more like proximal. Most cases you will have some form of a hepatomegaly which is there. Carry on.
So now diagnosis after provisional diagnosis after examination. So again, she is 4 year, 5 months old female child, first product of consanguineous marriage, presented with failure to thrive, gait abnormality, bony deformities, polyuria, polydipsia. On examination, she had features of severe growth failure, rickets, and acidotic breathing. So we'll now narrow down the diagnosis to RTA or very less likely CKD.
I think you can be very bold to say here that this is most likely a distal RTA, not even a RTA. You can be more like, you can be, of course, not be 100% sure, but this looks like a distal RTA. So if you really look into most cases that come like this, you will be able to make a diagnosis. Then only you should look at biochemistry. So whenever you see the case for the first time, do not look at the reports. Look at the child first, because otherwise you will get unnecessarily biased on that regard. So how will you work up now in this?
Sir, first we will go for the basic lab investigation. Sir.
Yes.
We'll go for the hemogram. We'll go.
Would you do a radiology?
X-rays must.
So you have to first confirm, because
Yes.
theoretically, as Dr. Vibha said, you need to be very sure whether it's really a metabolic bone disease, which is likely, but you have to document that this could be a skeletal dysplasia. If it was skeletal dysplasia, Dr. Vibha, which form of skeletal dysplasia are you looking at here? With this sort of a deformity and failure to thrive.
If we combine both skeletal changes and polyuria, polydipsia, some form of deficiency imperfectus can present like that. But the factor issues will be there, other manifestations like there are present, and some like some dysplasias like spondyloepiphyseal or other.
Some of the severe bone deformities which can present include something like Jansen's dysostosis, which is very severe, but they're usually at birth. And so that becomes less likely. But then clearly RTA is the most likely diagnosis. Carry on.
So we have done the basic screening. The hemogram was normal. SGPT and creatinine were within normal limit, ruling out CKD. Calcium was on the lower limit of normal, which is in this case it was 8.9. ALP was high, 991. Phosphorus was low, 1.96 milligram per deciliter. Vitamin D was normal, 56 nanogram per ml. Sodium was 141 and potassium was on the lower side, 3.2.
If you look at these reports, what do these tell you? Low phosphorus, what does it mean?
Low phosphorus can be present in any rickets.
So it's basically ruling out renal failure.
And
It's ruling out some of the PTH problems, but it is not of any significance beyond that. What about ALP?
ALP is usually
Which condition is out?
ALP is in hypophosphatemic rickets. It is out.
No, hypophosphatemic, which is completely out. You will not even think about it. Alapan?
ALP deficiencies.
Hypophosphatemia. So hypophosphatemia is obviously out because that will be zero. But now the question is, when your ALP is high, what is the one which goes in which type of RTA? Is it favor of RTA or not?
Decimals are much more common in.
They're much higher.
ALP
ALP is the marker of
bone formation.
bone formation. Bone formation.
Histology, it is just the acidosis is there, so the bone resorption is there mainly, no formation was
there. Overall, that's why your turnover is not. So this is classically, you are supposed to have a normal amount of ALP. So that is the point you is going against again. But then this is not 100% mechanism. If you have distal RTA, can you have hypocalcemia?
Hypocalcemia.
You're losing a lot of urinary calcium. Theoretically, you can have hypocalcemia. If you also have low vitamin D, you will have hyperparathyroidism. Hyperparathyroidism will further lower your phosphorus level and it may increase your ALP level. So it's not that that's absolutely against that in that regard. So what about this potassium? How do you interpret this potassium?
It's on the lower side, dash. Distal artery or proximal artery. Rule out distal artery.
So proximal RTA it's less likely because there it is usually on treatment, while distal RTA you can have it right away. So this picture clearly tells you this thing. This is not renal failure. You're dealing with RTA. Now, whether it's proximal or distal is something you have to decide about subsequently. So how will you differentiate proximal from distal?
First of all, after confirming RTA,
Mhm.
we'll go for urine pH.
Okay.
And after giving bicarbonate, we'll go for fractional excretion of bicarbonate.
Okay, so there are three tests to differentiate proximal from distal RTA. One, you said urine pH. So everybody who has a acidic blood should have a acidic urine. If your urine is not acidic, this is distal RTA. Your fractional excretion of bicarbonate should be high if it is proximal RTA. And third is urinary blood to carbon dioxide difference, which will give you a clue in that regard. So from here, the next test logically would be
Blood
to
gas.
look at a blood gas, and then you can go forward from there. So can you show the blood gas, please?
This was X-ray picture,
Yes.
which was suggestive of rickets.
So this X-ray picture, this is looking like the whole bone is being eaten up. That sort of a scenario. So it's like illusion. It's not. So when you say rickets-like picture, rickets is because of two things. One is that your growth plate apoptosis is not happening, so that thing is becoming there, and then you have secondary hyperparathyroidism. Here, the predominant effect is because of acidosis per se. So it's looking like the bone is being eluted, and there is no fracture. But if you go allow them to go for any few years, they will develop fracture.
Metacarpal, microfracture.
Okay, yeah. So loser zone, that sort of a thing is there. So it's a very, very osteopenic bone
Sorry.
that you are seeing, and there is generalized decrease. There is no clear-cut subperiosteal resorption, suggesting of hyperparathyroidism. So this is more likely to be a case of a RTA-like picture. Yeah, carry on.
So subsequently, we did her blood gas and urine pH. Blood gas was normal anion gap metabolic acidosis, which is hyperchloremic, and urine pH was subsequently found to be 6.5.
So this is, I think, the clinching diagnosis here. So what are we seeing here is that there is a metabolic acidosis, first of all. How do you identify metabolic acidosis?
First, we'll look for the pH values.
Yes.
If it is less than 7.3, it is acidotic. Then we will look for the CO2 and bicarbonate levels. If CO2 is high, it is respiratory. And
Which is the single most important marker of metabolic acidosis?
base excess.
Yes. So base excess is most important. Now, your pH may be normal also. You can say it's partially compensated or compensated, but base excess is most important. So what was the base excess?
It was, I think, remember it's minus 18 or something.
It will be very high because bicarb here is 8.8. Now, what does this bicarb tell you? If it is RTA, is it distal or proximal? 8. Okay, or do you think it can go for
It is too low.
this bicarb? Put the you will not lose. So this should not happen in proximal RTA. So it's a self-limiting. Usually, figure around 15 to 20. Classically going more in favor of a distal RTA again, and your urinary pH. So what are the caveats in evaluation of urine pH? How do you take the sample for urine pH? And what other things can cause a false positive, false negative for urine pH? And what should be the blood pH when you do the urine pH? So in a nutshell, you tell us about urine pH. Whatever you know about.
Urine pH is ideally taken in a morning sample. It should be taken under oil so that carbon dioxide should not be. That means that above the urine, there should be a oil layer below which we should take it actually. No.
Yes, sir.
Urine pH sometimes we in ureage infections like
This is one thing. And then what's the blood?
the normal rate. 1.3 to 10.4.
No.
In मतलब in RT.
Yes. You don't correct. That's the biggest advantage. The urine acid, just take it. You don't need to do a soda bicarb loading or something. You do add on the time of uses. So one thing very important, you said that you should put some oil in the collecting tube and then the urine. Okay. Second would be precautions. What can cause this file hormone again?
Urinary pH could be that means there is no acidification is there. So
Acidification is that
Urease
this
produces
produces bacteria as well.
if you have some infection, you have to check it. Next, you have to look at the food method.
sodium. Dehydration.
You have infection, you may have falsely high urine.
Yeah.
You should exclude, you should not. As well as when you are then you will be doing that as part of the work. And evaluate. Urine sodium anyway. So urine sodium you will be anyway doing because of the urinary anion gap. So you should look at urine routine, urine sodium. If they are normal, then only you can interpret the urinary pH. So now you have got a acidic blood and a alkaline urine. So when we say alkaline urine, the urine is like 5.5, somewhere below that. So some people use 5.3, some people use 5.5. So if it's more than 5.5, it is considered to be an acidic urine. So here alkaline urine. So this is clearly going in favor of a distal
Yes, sir.
RTA. So now you have diagnosed distal RTA. What are the other possibilities like causes that you like to work up now?
So we will first we have to look for the genetic causes, sir.
Yeah.
Defect in the ion exchanger or defect in the sodium.
So some of the genetic
Genetic.
causes. Can it be some acquired form which can cause this?
Acquired, sir, can be due to some obstruction in the kidney, sir. Can be due to drugs. Can
Yes.
be due to UTIs.
Some autoimmune, although too
conditions.
early
Yes, sir.
for presentation for this. So carry on from here. How will you work up from here?
The final diagnosis was made based on the lab distal RTA, and further etiological workup is being planned for this patient. We are planning ultrasound and urine calcium creatine ratio for this patient, and subsequently we are planning for a genetic workup in the patient. You have
So
started.
now you have diagnosed it as the distal RTA with hypokalemia. Now the question is what happens to potassium once you start bicarbonate in proximal RTA and in distal RTA?
In proximal RTA, sir, there will be hypokalemia on treatment, sir.
Yeah.
And in distal RTA, the potassium levels tend to improve towards the during
As you
management.
treat, the potassium will improve. Why? One, you have given soda bicarbonate, your volume is more, aldosterone is less. So hyperaldosteronism, which Alapan was talking about, is taken care of. Acidosis is better. So intracellular acidosis causes the loss. That will be improving on that. Third, proton potassium exchange. So everything will improve.
Yes.
But why does it worsen in proximal RTA?
Because in soda bicarb, there will be a more load of sodium, sir, which will
Yes.
lead to more activation of RAS axis. There will be more potassium loss in the urine and more sodium absorption.
You are correct that the sodium is more. More sodium is filtered. It goes to the collecting duct, and there the sodium has to be absorbed.
Yes, sir.
So in exchange of that, potassium
Yes.
will be lost. So this is paradoxical. In proximal RTA, once you give them soda bicarbonate, potassium will go down. In distal RTA, potassium should go up. So which patient of distal RTA will you like to start potassium right away as far as treatment is concerned? When you're starting bicarbonate, you know that which patient will you give potassium?
Hypokalemic periodic paralysis. Yes.
0.5. Take that amount. And what we saw in the other group, there is a hypokalemic paralysis who had presented with 2.1 potassium. Now we were giving a lot of potassium, but now with bicarbonate, her potassium has gone up to 5.6, which means that now the acidosis is better and then everything is improved on that. So yeah, carry on.
So she has improved clinically, and long-term follow-up is awaited.
So what do you expect in terms of clinical response?
The clinical response, her acidosis will recover, her growth will recover, sir. And bony deformities may not recover, but definitely she will grow, gain weight. She will height will increase, and acidosis will resolve, sir.
So generally there will be improvement. This is a younger girl. So we do see, even I've seen patients who have come to me around 10 years, 12 years of age with severe fracture. They are now started to walk and everything. So we expect a good response because especially in this say there's a lot of malleability which is there in terms of the bone overall. But one thing which you have to be very cautious is nephrocalcinosis because that may already be present. And if you have persistent hypercalciuria, what can you think of in terms of treatment options?
First of all, in this section, you can think about phenylcalcium yeah, to decrease the PTH level and subsequently calcium will be. Yeah. No, that will be in the other way. So
Diuretic, diuretic.
What the precaution you should take? Salt intake
could be less. Protein intake would be less.
sodium again. It is again because of the sodium. So sodium is more, calcium will come out again. So correction of happens. Then theoretically less amount of salt. If you use thyroid, it's something which is not routinely recommended now. But generally, if you correct we have published a long time ago in terms of very good outcome in terms of growth or distal RTA on follow-up. Yeah, carry on.
So now we'll have an overlook about rickets. So rickets most commonly is due to nutritional rickets is most common due to vitamin D or calcium deficiency. This kind of ricket at presentation should be treated with adequate doses of calcium and vitamin D for around 12 weeks, and then subsequently we should go for X-ray. And if X-ray is suggestive of a line of healing, then we should continue the treatment on nutritional deficiency lines. If there is no line of healing, then we should think about refractory rickets. And in refractory, we have calcopenic rickets, in which we have PDDR1 or can be due to renal.
In this case, you did not give a course of vitamin D. Why? Why did you consider refractory rickets right away?
Because few cases like severe growth failure with severe deformities, we can directly consider as refractory.
So, in other words, I'm asking what are the pointers to refractory rickets at diagnosis? So you said failure to thrive.
Severe failure to
Then
thrive, severe bone deformities, the fractures,
fractures, very important term. Then polyuria,
polyuria.
acidotic bracing. So any other features? So this case had everything. If somebody says that, okay, I'll give them for 12 weeks, that doesn't make any sense. This case requires immediate evaluation. Yes?
So in refractory, we have calcopenic, in which VDDR1 and 2 are there. Renal failure, malabsorption can be there. Acidosis, which is proximal or distal. Phosphopenic, hypophosphatemia rickets, Fanconi syndrome, or malabsorption.
Could this have been hypophosphatemic rickets?
But
So can hypophosphatemic rickets have acidosis?
No.
Can it have hypercalciuria?
No. Calcium and
Calcium was normal in this case also. What about the hypercalciuria? Can you have hypophosphatemic rickets with hypercalciuria?
it can be
Calcium sensing.
defect of sodium potassium transporter 2AC. Phosphorus transporter.
NPT.
Yes, sir.
NPT2 defect will cause hypophosphatemic rickets with hypercalciuria. Tens disease is another one which causes microglobulinuria with hypercalciuria with hypophosphatemia. So the first diagnosis, now let's come back to how the case presented to us. It was labeled as, it was told to us that we have a case of hypophosphatemic rickets and you have to evaluate and manage it. So if you just start saying, okay, hypophosphatemic rickets, then you will stop there. But if you look at child, you know very quickly this is not hypophosphatemic rickets by any chance.
Yeah.
So this is clearly a case of distal RTA. Yeah, carry on.
Now we'll compare various forms of rickets. Phosphorus will be low in all kinds of rickets except for renal failure and pseudohypoparathyroidism. Calcium will be low in all except for hypophosphatemia rickets.
So RTA, calcium, may or may not be low. Means it depends upon the compensation phenomena. So as you said, mildly low, but PTH will be high. So if you have normal calcium and normal PTH, that is going more in favor of a hypophosphatemic ricket.
And urine calcium will be high in RTA and will be normal in others. And in RTA and renal failure, there will be acidosis and pH will be normal in others.
So if you go to combine all this, what you are seeing, low phosphate, lowish calcium, PTH we did not measure, high urinary calcium. So this is going more in favor of a RTA, clearly in this regard. Yeah.
So now approach to refractory rickets. Like once we have given a course of 12 weeks of calcium vitamin D, if the rickets is refractory, there is no line of healing, then we should re-evaluate the phosphorus levels. If phosphorus is high, then we have two possibilities, CKD or BHP. Creatinine will differentiate between CKD and PHP. High creatinine is suggestive of renal failure. And if the creatinine is normal, then we should go for PTS level.
Why does PHP cause bony deformities and not hypoparathyroidism?
Phosphaturic HGF23 mediated.
So PHP is
It presents like hypophosphatemia ricket. So as a resistance at the level of HGF23 is a receptor that acts via G-coupled protein.
You're creating more confusion. So what happens in pseudohypoparathyroidism? You have a PTH resistance. Now in hypoparathyroidism, you have no PTH. So PTH is not acting on the kidneys at the 1-alpha hydroxylase, not acting at the level of urinary calcium, not acting at the level of bone. But when you talk about pseudohypoparathyroidism, it is a what type of disorder? Genetic
Imprinting risk.
imprinting disorder. So in some areas where you have biallelic expression of the GNAS1, you will have different manifestations in which only one of the alleles, the mother's allele is expressed, you will have different manifestations. So in PHP, what is happening? Your renal responsiveness is not there. You are not producing calcitriol, but you are conserving calcium and you are acting on the bone. So what will happen? Your PTH will go up. So bone effect will be there. So effectively, you have hyperparathyroidism at the level of the bone and hypoparathyroidism at the level of the 1-alpha hydroxylase, and urinary calcium is preserved. So if you compare HP versus PHP, in hypoparathyroidism, you will have hypocalcemia, relative hypercalciuria for the level of calcium, and bones, nothing is happening. PTH is not working. In pseudohypoparathyroidism, you will have hypocalcemia. You will not have hypercalciuria even if your calcium levels go up, and your bone turnover is increased. So that's why you will have rickets. That is why in hypoparathyroidism, you want to maintain your calcium level between 8 to 8.5 so that you don't cause hypercalciuria. While in pseudo-hypoparathyroidism, you have to maintain around 9.5 to 10 because the risk of hypercalciuria is not there, but your risk of bone disease is there. So if you want to counter the bone disease, you have to keep the calcium at a higher level. So PHP, that's why it is going to cause that from that regards. Yeah. Carry on.
If the phosphorus is low, then we should go for blood gas. And if blood gas is suggestive of acidosis, then we should straight away go for urine pH. Urine pH less than 5.3 is proximal RTA, more than 5.3 is distal RTA. If the blood gas is normal, then we should go for calcium and PTH levels. Normal calcium and PTH is suggestive of hypophosphatemia rickets. If the calcium is low and PTH is high, then it is VDDR and calcitriol levels will differentiate between 1 and 2.
In this case, clearly is going directly towards the
Distal RTA.
distal artery, which is a very clear fact. Scenario.
So briefly about the etiology of RTAs. Distal RTA can be genetic and they may have association like hemolytic anemia and deafness. They can be acquired also due to malabsorption, due to malformations, obstructions, UTIs, autoimmune disease like SLE or Sjogren's syndrome or drug induced. Proximal can be genetic due to sodium bicarbonate channel defect, carbonic anhydrase 2 defect, stenosis, tyrosinemia, fructose intolerance, galactosemia, and other defects.
So hepatomegaly, as you said, is the most important.
Yes, sir. And acquired due to drugs like diamox, aminoglycosides, topiramate, toxins like mercury, lead, and copper. And hyperkalemia is a different entity. It is usually due to RAS defect.
Does it cause rickets? Type 4?
Type 4 will not cause rickets
Why?
because there is no hypercalcemia in that.
Acidosis is very mild.
Minus.
So hyperkalemic RTA is basically because of high potassium. High potassium is inhibiting ammonium production. Is causing decreased potassium proton loss, so you will have acidosis. So that acidosis is not severe enough to cause RTA rickets. In our case series with Dr. Bagga that I had written, RTA is by far the most common cause of refractory rickets in Indian children. If you exclude renal failure, number one is distal RTA, number two is hypophosphatemic, number three is proximal, and number four will be VDDR. In our experience, also distal and proximal RTA are very, very important compared to hypophosphatemic, which is also there but not that common.
Approach to metabolic acidosis. When someone is presented with metabolic acidosis, we should always look for anion gap. If it is high, then it can be due to diabetic ketoacidosis, lactic acidosis, or organic acidemias. If there is normal anion gap, then we should straight away go for urine anion gap to rule out between gastrointestinal and renal loss. If the urine anion gap is less than -20, then it is due to GI losses. And if it is positive more than +20, then it is due to RTAs. Then we should straight away go for potassium levels. If the potassium is high, then we are dealing with type 4 RTA. If the potassium is low or normal, then urine pH will give us the clue that less than 5.3 is distal proximal and more than 5.3 is distal RTA. So a brief about classification of various type RTAs. Distal RTA will have the maximum acidosis. Potassium will be low in proximal and distal and will be high in type 4. Urine pH will be less than 5.3 in proximal and will be more than 5.3 in distal and type 4. Urine calcium will be high in distal RTA and will be normal in proximal and type 4. Fractional excretion of bicarbonate after giving a bicarbonate loading, it should be more than 15% in proximal and less than 5% in distal and type 4. Ammonium production is variable in proximal and it will be low in distal and type 4.
Suppose you have a child like this with rickets and you do a blood gas which is normal, can it still be RTA?
It can be proximal RTA which have a mild defect.
Yes, so proximal RTA can be missed, not distal RTA.
Yes.
Now, many people talk about incomplete distal RTA. Now, that term I won't think is a significant term in terms of a distal RTA causing bony deformity. Incomplete distal RTA may cause some failure to thrive, may cause nephrocalcinosis, but it will not cause rickets. Because you need much more acidosis, much longer duration of acidosis to cause rickets. If you look at this case, the child was severely failing to thrive and then they gave us chance for 2 years. If somebody had diagnosed, they could have given bicarbonate and prevented these bony deformities. So it's very unusual for incomplete forms to cause rickets, but proximal RTA is a very, very difficult thing. Often the pH may be normal, urine pH may be variable. So what other clues will you look at on urine examination to identify that this could be a proximal RTA?
Urine pH.
So always be wary of glucose urea, isolated glucose urea, and then amino acid urea also, but that is not something easily available. Glucose urea will be there, easily available. Yeah.
So briefly about the management, proximal RTA, we have to give a bicarbonate dose at a higher dose, 5 to 6 millimole per kg per day. Phosphate will be also required in a dose of 30 to 50 mg per kg per day. Potassium supplements are usually required with treatment to prevent hypokalemia. In distal RTA, bicarbonate is given in a low dose, 0.5 to 2 millimole per kg per day. Potassium levels and the hypercalciuria usually improve with the treatment of acidosis. However, if the hypokalemia is severe at presentation, we should start with potassium.
Bicarbonate, usually in the beginning, you will need to give a higher dose because there is a lot of accumulation. See, what is the normal production of bicarbonate in the body? How much do we produce per kg?
70
Yes.
millimoles per kg.
So, no, it's not millimoles per kg. One millimole per kg, 70 millimoles, you can say 70 to 100. So 1 to 2 is the max production. So if you are just able to replace that much bicarb, you should be fine. But suppose somebody is having accumulating that proton over a long time. So initially you need to give more dose. When you treat rickets, what dose do you give for treatment of rickets?
Vitamin D.
Yeah.
That depend on the age. For less than 1 year, we give 2000 units per day for 12 weeks.
And what is the physiological requirement?
400 units per day.
So you're giving 5 times a dose because you have to bridge that gap. Same things here. You may need, sometimes I have gone up to 3 or 4 also because it may take time for this acidosis to correct. Once it's corrected, you can come down on the dose from that.
And thiazides can be used if the hypercalciuria is not corrected with the correction of acidosis. And typhoid is a entirely different entity. We treat with high dose of fluorouracil if there is RAS defect, and along with that, alkali is also given. So this was the presentation.
Okay, thank you, Dr. Sandeep, for a wonderful discussion.
Thank you so much.
So all of you can go and have a look at our website, our books, which are there, our mobile application, which is there, our courses, as well as the website, which is there. We'll see if there are any particular questions there, which we like to address. So we have got Dr. Medha. Periodic paralysis points to distal RTA in which condition? So if you have periodic paralysis, that could be part of hypokalemia because of either distal RTA or a possibility of a celiac disease, which can also cause a similar picture. So I think with that, we come to the end of this. So this is a very interesting scenario. And we'll be coming back with our PG lecture series later this month. And then subsequently, we'll move forward to the interesting case scenarios as well.